Yeah. So you're right. The epiretinal membranes had a few names in the past, mainly because until we had relatively modern imaging in the retina, we didn't really understand what this was. So sometimes it was called macular pucker, sometimes it was called cellophane maculopathy. It has a few different names, but essentially what it is a membrane of scar tissue forming over the surface of the macula. It generally happens when there's been some sort of trauma to the retinal surface, and this is one of the reasons that it's linked to posterior vitreous detachment and what we call vitreomacular interface disorders. Because you can imagine if there's been a little bit of stickiness to the gel and it hasn't come away cleanly, it could pull on the retina a little bit, and as it does release, maybe it's not stuck so firmly that it actually causes a hole, but it still traumatizes the surface as it peels away. Sort of like, when you peel sticky tape off your skin and maybe you lose a few hairs and it looks a bit red and angry underneath. The same thing can happen on the retina. And for reasons we don't really understand, some people are just more prone to developing this scar tissue than others. And I liken it to, the way that some of us get a cut on the skin and it heals over with no effect at all. And you get the same cut on another person and they get a lumpy keloid scar that's really obvious. So there's obviously, genetic factors that predispose people to these things. But essentially, it's the body trying to respond to what it sees as an injury on the surface of the retina, either happening during a posterior vitreous detachment or happening due to trauma to the eye or bad inflammation or an infection in the eye, something that's triggered that healing response, and the body's overdone it a bit, and we've ended up with this scar tissue membrane over the surface of the macula. The problem with scar tissue is it contracts. And so if this membrane is thick enough, then as it starts to contract, it pulls the retina with it and it wrinkles it up like wrinkles on your shirt. And the problem is, you can imagine if you took the film in a camera and scrunched it up so it was all covered in wrinkles and folds and things and then stuck it back in the camera, you're not going to get a very clear photo. And the same thing happens with the retina. Because it's been pulled and stretched and warped out of shape, the same thing happens to the vision. And so, in those cases where we've got an epiretinal membrane that's symptomatic or is clearly getting worse, even if the patient's not really noticing the symptoms terribly much yet, it's generally worth operating on those to release the traction and let the retina settle back into its normal position to improve the vision.
And so, if somebody gets an epiretinal membrane condition in one eye, does that mean that it's likely they're going to get that same condition in the other eye, or it's really just
not necessarily? It does depend. There are, we do get some patients who develop it in both eyes. We get some patients who only develop it in one eye, and so I would say the majority of epiretinal membranes we see never actually progress to the point that they need something done about them. So when they've looked at how often these things happen, we say, about a 5% risk, maybe 7% risk, over your life of developing epiretinal membrane. But the majority of people with it wouldn't even know they had it. There's, it's there, but it's not really causing much of an issue. The number of patients that I need to operate for epiretinal membrane is only a small proportion of the patients that I see with the condition, because, like we were saying, with scarring on your skin, any cut you get is going to cause a scar, but not that many of them are going to be noticeable. And epiretinal membrane's the same. If it's very mild and it's not impacting on the vision and it's not progressing, then there's no reason to touch it. We just watch it for a little while, make sure that it's not getting worse, and nothing more needs to be done.
And is the recovery process simpler than macular hole treatment, for example?
It is. So for most epiretinal membranes, the operation, again, it's a vitrectomy. It's the removing the gel from the eye is the first step. And then the surgery, in this case, we're not trying to close a hole in the retina. We're just trying to remove this abnormal scar tissue. And so it's what we call an epiretinal membrane peel. So we put dyes in the eye in the same way that we do with macular hole. So we put a dye in the eye to stain up the tissue of interest. It's a blue dye that shows me where the scar tissue is. And then with micro forceps, I'm able to just gently remove that from the surface of the eye. And removing the membrane itself is enough to allow the retina to sit back in its normal position. So we don't, in these cases, we don't need to put a long-acting gas bubble in. Instead, I'll generally do what's called a partial fluid air exchange, where at the end of the operation, I'll put a small bubble of sterile air in the eye, enough to seal up the little puncture wounds that we've made, but not so much that the whole eye is full of gas. And by doing that, it means that the bubble doesn't hang around as long, because something we didn't really touch on with macular hole is that when you've got a bubble of gas in the eye doesn't work properly. It's like having your eye open in a pool underwater. Your eye's not meant to function with water outside of it. It's meant to function with air outside of it, just the same as it's not meant to function with a gas bubble inside it. And so that makes the vision very blurry until the gas bubble goes away. So, if we don't need the bubble to be there for several days, there's no reason to put a longer acting gas in. So with a partial fluid air exchange, there's a bubble in the vision that moves around inside the eye and is a little bit annoying for usually 3 or 4 days or so, and then it's gone. So again, I usually tell patients, look, just be aware when you come out of the operation, you're going to have this fluid level in the eye. It's going to see, there's going to be a bubble of gas. You're going to see this line across the middle of your vision. And over the next few days, that line's going to get lower and lower. Eventually, it'll form into a round ball that'll drift around inside the eye as you move. And then one morning, you'll wake up and it'll be gone.